Hi, my name is Angela James and I'm a pelvic health physiotherapist. I'm the owner and principal physiotherapist at Sydney Pelvic Clinic, and I'd like to thank IUGA for inviting me to present at the International Symposium on Birth and Beyond on a topic that I'm passionate about, the management of pelvic girdle pain using an evidence-based and whole person approach. So in 2008, Andre Vleeming further defined pelvic girdle pain as a separate category to low back pain. They defined PGP as pain between the iliac crests and the gluteal fold, particularly in the area of the sacroiliac joints. The pain can radiate down the posterior thigh and can also occur in conjunction with or separately to the pubic symphysis. The endurance capacity for standing, walking, and sitting is diminished. Fast forward a decade, and we are now adopting a broader view on pain, with it no longer being acceptable to consider PGP solely as a peripheral phenomenon. And this contemporary view, or a biopsychosocial approach, helps to define high quality versus low value health care. Clinically, we need to consider all of these factors to have either a facilitatory or inhibitory effect on pain, and it's up to our clinical assessment skills to determine what's influencing our patient at any point of time. And I think we can all agree that our patients presenting in the pregnancy or the postpartum period with PGP are having impact of many of these factors. We know in the body in pregnancy, there's widespread sensitization. We know there's often changes in sleep quality, particularly in the postpartum period. We know there's huge fluctuations with hormones. We know there's big changes in motor control and changes particularly in the abdominal and pelvic floor area. In the social context, we know that many patients are going through big transitions to become pregnant, changes in their relationship, changes in their identity, changes in their work capacity. And we also know psychologically that many women suffer from mental health issues in this time period. We know that the presence of mental health issues such as psychological distress or depression can contribute to pain and the persistence of pain. We know that the way that they think about their pain can also enhance their pain experience. And often these women have low self-efficacy, not sure what to do or how to manage this new pain in their pelvis. So the prevalence, well, in a recent study, up to 44% of Australian women report presence of PGP in pregnancy, and 10% of these women will go on to have chronic or persistent pain. We know that PGP has a high impact on sick leave, healthcare costs, and a negative impact on quality of life. PGP, more so than low back pain, has a negative impact on psychological and emotional well-being. And women who report pregnancy-related pelvic girdle pain are often dismissed as their pain is said to be a normal part of the pregnancy period, and are then not referred on for appropriate management. Now, what are the predictors of chronicity? And we need to be aware of these to ensure our patients are not the patients that go into this category. Now, we know the strongest predictor of chronicity is widespread pain, which can be determined using a good body chart and a number of positive pain provocation tests talking to our physical assessment skills. And a strong predictor of pregnancy-related pelvic girdle pain not becoming chronic after pregnancy is the belief that it won't. And this talks to our communication skills, making sure that we're giving that hopefulness to our patients and that sense of a prognosis, so they know that it's likely to be time limited to pregnancy. And other predictors include psychological distress, negative cognitions, and sleep dysfunction. And this speaks to the importance of screening for these features. Now, what is the relationship between pelvic girdle pain and lower urinary tract symptoms? Well, we know that these two things combine in up to 50% of our patients, and the presence of lower urinary tract symptoms in PGP patients increases the risk of developing chronic pain. It increases the risk of experiencing anxiety, depression, and reduces participation in physical exercise. So we also know that it's not routinely screened for many of our patients. The barriers being the lack of knowledge of their healthcare provider and their routine clinical assessments, not including screening for lower urinary tract symptoms. And facilitators are improving education and knowledge and communication skills, and also having better pathways. So if they are finding that there is presence of lower urinary tract symptoms, they can refer on to an appropriate healthcare professional for help. So what about the relationship between pelvic girdle pain and pelvic floor muscles? We know on one hand during pregnancy and particularly postpartum, we have a enormous challenge with weakness of pelvic floor contributing to the increased likelihood of pelvic floor muscle dysfunction, such as urinary incontinence or pelvic organ prolapse. We know also we have strong evidence supporting pelvic floor muscle training based on a strength program to reduce stress urinary incontinence in pregnancy and into the long term. But is there something different that our patients with PGP need? Because we know through research that studies have shown that they are more likely to have increased tone, shown by a reduction in levator hiatus and elevation in vaginal resting pressure, or an increased tenderness in obturator internus or levator ani palpation. And what are the clinical implications then for routine pelvic floor muscle training for these patients? And what about the impact if this is unaddressed into vaginal birth, knowing what needs to happen for the pelvic floor for vaginal birth? We know that this is the big moment for the pelvic floor. It doesn't get much bigger than vaginal birth. We know our pelvic floor needs to stretch 3 times beyond its normal length, and the nerves have to do a similar thing. So they strain up to 30%. And most muscles or nerves are actually impacted if they stretch beyond about 1.5 times their resting length. So it's an enormous ask for the pelvic floor. We also know injuries are relatively common, so up to 30% of first-time women will experience a levator avulsion, either unilateral or less common bilateral. And so what are the implications to this reduction in pelvic floor muscle function to the likelihood of pelvic girdle pain or even hip pain, the presence of these conditions later in a woman's journey if we don't regain that function? We know the impact on pelvic organ prolapse and urinary incontinence, but what about our musculoskeletal conditions as well? So my talk is to look at the clinical management of these patients. So it's important that we have a framework when trying to best help our clients. And this clinical management framework is from the team at the ICS. And for this framework to be successfully integrated to improve patient outcomes, it must be underpinned by a strong therapeutic alliance and a commitment to providing evidence-based and patient-centered care. But the key components of this framework is screening, assessment, making a clear diagnosis, formulating an individual treatment plan, and being able to reassess to see if we're being effective. So screening is considered the pre-consultation phase. So this could be used as an opportunity to screen for the impact of the pain as well as general pelvic floor disorders. So specifically, we can use the pelvic girdle questionnaire, which is the only one targeted to this cohort, but there are others that we can look at in terms of the OESTRI disability index or simply the patient-specific functional scale to really hone in what's bothering the patient, such as is it rolling in bed or standing out of a chair or the first few steps. We also definitely need to use screening tools, specifically assessing for psychosocial aspects to the patient's experience. So central sensitization inventory is a good one, which is proven to be able to show signs of psychological distress. Pain catastrophizing scale gives us a good indication to whether we really need to pivot and provide pain neuroscience education. And we need to be looking for signs of stress, anxiety, or depression. And I also really encourage people to look at pain self-efficacy because I find this is often low in patients with pelvic pain. So our assessment, when we actually are doing history taking or the patient interview, really needs to seek out to gain clarity around the symptoms and its impact, as well as our patient's thoughts, beliefs, and fears. We need to do a pelvic floor screen to look at the presence of lower urinary tract symptoms and the impact on their daily life and their exercise levels. And we also need to keep in mind if there's presence of 3 key features, then they're strongly predictive of the presence of central sensitization. So it's not just the screening tools, it's also our communication skills and history taking that helps us to work out which factors are heavily influencing our patient. So these 3 factors are pain disproportionate to the injury, disproportionate aggravating and easing factors, so if everything hurts versus just mechanical type pain, and presence of the psychosocial screening, psychosocial symptoms. We need to keep in mind the differential diagnosis, so screening what's above and below, so lumbar spine and hips, and we need to keep any bony related changes such as stress fractures in the pubic bone or the sacrum after birth, or significant pubic diastasis or coccyx injuries. Our physical examination needs to include these key features: observation, and we can look at our patients just walking into our rooms to see if they've got the typical waddling gait for anterior pelvic girdle pain, or if they're trying to offload one particular side. We need to screen, as said in the previous slide. We need to look at functional tests, and the two good ones for PGP are the 5 times sit to stand and timed up and go. It's important not to do those if the patient is particularly acute and particularly bothered by standing up, but at some point it gives good data, and you can compare it against normative data, and research has shown that changing it by about 20% is clinically significant for your patient. We need to look at specific pain provocation tests, such as the pubic symphysis and long dorsal ligament palpation, and the Laslet's sequence of 5 tests, and 3 out of 5 being positive can give us a strong indication whether sacroiliac joint is involved. We need to consider a pelvic floor muscle exam, and that may be using transabdominal ultrasound or a vaginal exam. We need to be clear about what we're trying to achieve with that assessment. So we know that there are limitations in assessing tone with transabdominal ultrasound. So just being mindful about what this screen is looking for, and of course making sure that the patient is comfortable and aware of what you're trying to achieve. So at the end of that, we should be arriving at a clear diagnosis to see if they indeed do have pelvic girdle pain and what is influencing their pelvic girdle pain. We like to be able to subcategorize into anterior pelvic girdle pain or posterior pelvic girdle pain, or both, knowing that if there is both anterior and posterior, it is a predictor of a poorer outcome. And then we should be able to sort of bring it all together and formulate this person-centered approach, which typically involves a combination of these 4 things. So education and explanation is really important to make sure that the patient has a clear narrative about what's going on in their body. We need to be aware if we need to turn that towards pain neuroscience education, if there's a lot of catastrophic thinking around their pain and a lot of nervous system contributors. We also need to look at manual therapy, except if patients are highly sensitive and have really low self-efficacy. But if you can prove their pain is changeable by adding in manual therapy, and particularly if you can change a particular aggravating activity, then that's really useful. But I highly recommend, if you found something that's effective with your manual therapy skills, that you teach the patient on how to do that, so you're building self-efficacy at the same time. We need to look at lifestyle factors such as sleep, reducing stress, and of course exercise therapy. It has conflicting evidence, but I think we can all agree that exercise is a positive thing for most of our patients. So the guidelines say that all women except high risk should be exercising up to 150 minutes of moderate intensity exercise plus 2 resistance trainings per week. We know we need to help our PG patients get to a point where that is possible. And as the characteristics of an effective exercise program for this group is that it's personalised, it's targeted to the patient, and it has appropriate corrections and modifications. And it needs to be avoidant of symptoms of PGP. If it does trigger PGP, it can be a real barrier for the patient's adherence. Also, we know that exercise does more than just treat the local tissues. We know it reduces stress and reduces sensitization, and it really improves self-efficacy and reduces inflammation. So I think we could probably all agree that exercise is good as long as it's targeted and personalized to the patient. So that is my 15 minutes. I hope you enjoyed the presentation. I'm more than happy to take questions at the end, and look forward to hearing the other speakers. Thank you very much.